So we're going to just do a quick blurb on gunshot wounds. This is one of those slides that I'm going to kind of move away from because it's absolutely not all that relevant to you. I will tell you that if you have a penetrating injury due to a gunshot wound, finding out the caliber of the gun has very little importance to you. Getting that patient to definitive care is far more important than you trying to figure that out. If somebody tells you that they heard 5 or 6 shots, you may be looking for multiple wounds. But again, getting that patient into the rig, into the definitive care is far more important. In regards to impaled objects, if the object is still in the person's body, we never want to try to actually remove that. That's something that we want to have help with to try to cut the particular object, and we're going to transport that object with the patient. We're going to let the surgeons determine the best way to remove the offending object and whether or not they need to surgically remove, or they can remove just by retrieving it manually. Anytime you're dealing with an open neck wound, remember that there are massive structures in there that can become very life-threatening. You may not see a whole lot of bleeding externally, but they could be bleeding underneath the skin into the thoracic cavity. So we want to make sure that we're taking appropriate measures on this. This should be cover that wound with a occlusive dressing of some sorts, and try to keep their head and neck movements to a minimum, because if we do have something that's very delicate and has maybe just a fine kind of amount of damage to it, we don't want to let it get worse. So you can put mild pressure on there, but we don't want to like put them into people's sleeper, right? We're not going to put them in a chokehold trying to stop bleeding. If you can stop bleeding on one side, the side that's injured, that's appropriate, but never try to actually clamp off the blood supply to both sides of the brain. So in regards to bandages and dressings, we want to make sure that we're placing a dressing over the top of the wound, and then we're going to use some kind of bandaging like a Curlix or something of the like to keep those particular dressings in place over the wound. And you can use tape, triangles, or ace bandages. All of these things are appropriate, but the thing that you need to keep in consideration is that if you apply too much pressure, you can actually cause more damage. And the only time that we should be worried about controlling or keeping more pressure on a wound is if it continues to bleed. Now we're going to shift gears and move into burns, and burns are really, really serious, and they can be extremely painful. Again, depending on the significance of the burn, we're looking at, are the nerve endings destroyed or not, and then how much damage and over what surface area. So a burn by technicality is when the body receives more energy than it can absorb without injury, and the result is that the skin will begin to degrade, and then the cells will lyse, and then cause this kind of fluid shift. So sources of burns are again thermal, electrical, chemical, and then radiation exposure. So the pathophysiology of burns is local and systemic responses, and this is a release of catecholamines, the decrease in blood flow to the injured area, and then the fluid shift phase. And this again is kind of where we get those blisters and things of the like. The tissue damage reduces the ability to regulate core temperature, and that's if we've lost the skin. So if the skin has been burned away, we're now with open tissue that is, again, leaking fluid out, and that is obviously going to evaporate, and we have that lessened ability to kind of regulate the temperature of the tissue underneath. Anytime that we have any kind of burning or anything like that where we have fluid shifts, we have less oxygen transported to the tissue that's around it, and we can be diverting a lot of fluid away from organs and causing hypoperfusion. So in regards to the burn processes that can actually cause renal failure or liver failure, dysrhythmias, and heart failure, this again is because we've damaged cells to a point where they lyse, or again, the cellular membrane ruptures and it leaks all the internal structures and fluids and electrolytes into the bloodstream. This can clog the kidneys up, right, causing that renal failure or the liver failure. The electrolyte imbalance from the sudden shift of potassium levels can cause dysrhythmias and heart failure. As the burn destroys skin, a tough leathery substance known as eschar is produced, and this can actually cause that compartment syndrome because it really doesn't want to flex and move with the swelling that's going to be associated with a particular injury that was just caused. Again, that skin that's missing is now a barrier that is missing, and so that patient is really highly at risk for infection. Obviously the hypothermia and the hypovolemia, because we are losing fluid. It's causing the evaporation, which is now losing the body temperature as well. And all of these patients will typically show you some kinds of sign or symptom of shock. When we're dealing with burns to the airway, this is significant. These are almost nearly impossible for you to deal with as an AEMT. We really want to have an ALS intercept or get that particular patient to the appropriate facility as quickly as possible. Circumferential burns of the chest can really compromise breathing because of that scar, or just because of the pain from the actual tissue being damaged. The patient doesn't really want to breathe well, and we want to make sure that anything that's a circumferential burn of an extremity, that can have that kind of same compartment issue or some of the irreversible damages that we just briefly discussed. Now here's a picture of a couple of different types of burns. So we have that superficial burn, and think of this as your sunburn. Now a sunburn, although superficial, can be significant depending on how severe it is and how much surface area of the skin is actually burned. A partial thickness burn is where we actually start to see the blistering. You're going to see the fluid shift there, where the interstitial fluid is separating the epidermis from the rest of the tissue. And then full thickness burns, where we actually see missing tissue. This could be all the way down to the bone. These tend to have a lot less of a pain response out of that patient because the nerves, again, are destroyed. Now the severity of a burn depends on the depth of the burn, the extent or the area of the burn, and then the critical areas. Is this over certain organs or certain areas where there may be some significant blood flow that may be impacted by the burn? Is there a pre-existing medical condition? And then is the patient able to compensate for this type of shock? So if they're younger than 5 and older than 55, we already know that they're really not going to be able to deal with the real later stages of shock very well. And so these patients, absolutely, I mean, all patients should be high priority, but really be on your A game when you're dealing with patients that are really small or tend to be elderly in regards to a significant burn. So by now in class, you guys have all revisited your Parkland burn formula, and we remember that formula is 4 mLs times weight in kilograms times body surface area. And this is where the rule of nines comes into play, because the rule of nines helps us understand what that actual body surface area is so that we can calculate that initial fluid bolus that's going to go to the patient. So if you're looking at this picture, you see 3 persons, and this is obviously a very small child, like an infant to a toddler, up to a very small child that we'll say looks to be probably anywhere from 4 to 6 years of age, and then we have an adult male. And if you look at the body surface area and the head being the primary component that's going to change, and this is because small children, like around 2 to 3 years of age, will have a full-size skull and the face is not completely grown. So they're going to have a significantly higher ratio of head size to the rest of the body or the torso. And so that's why you see the shift as they go from little small children to adults. It goes from 18 to 12 to 9. But for the most part, the rest of it is actually pretty close, and it doesn't change a whole lot. If you're looking at the arms, it's 9 each, and that's circumferentially. And then the torso is 18 all the way across, with the lower legs only slightly shifting from 13.5 to 16.5 to 18. So again, anything that's involving the face of the head is going to be a significant shift in your proportions, and just try to keep that in mind. Don't ever let a burn be a distracting injury. Make sure that you're looking at the burn, but you're doing a full secondary. Don't get caught in the distraction. Classify your burn. Is it just a surface burn? Is it a partial thickness? Or is it a full thickness? Is this thing causing severe tissue loss? And again, try to remember that even just a simple sunburn, depending on the severity of it and the amount of surface area, this burn can be significant to that particular patient. What caused that burn? Is it simply a sunburn? Is it somebody that's been outside all day and didn't have the necessary precautions? Was it electrical? Was it some kind of radiation, or was it fire? You have to use the mechanism of injury to give you a high index of suspicion to, 1, keep you safe, and 2, figure out how badly this person could be injured based on what you know of the type of cause. So again, determine that type of burn in the MOI. Make sure that you're using standard precautions. You never want to have somebody else's body fluids entering your body from some kind of opening. And then if this has something to do with somebody else, where a power company or the fire department or ALS is needed, you should have them en route before you're even getting to the call. In regards to burns with your primary assessment, if you have somebody who has a significant cough, this may indicate that they have a respiratory burn. Make sure that we're listening to lung sounds, because we want to know if this burn is just in the mouth or if it's actually down into the lung tissue, where we can cause a fluid shift into the bronchioles, and this person will now have some kind of hypoxia, and the breathing process is going to become impeded, and the swelling that will be associated with it will also close down the respiratory tract. So make sure that we're doing this quickly, and we want to know whether or not this has any kind of involvement in the respiratory function of your patient, and get them off scene to the appropriate facility as quickly as possible. In regards to your history taking, the better you are with your history taking, regardless of your mechanism or nature of illness, the better off your patient's going to be when you do the turnover. So if we're talking about history taking, this is that OPQRST, and we're looking for pain, the redness, the swelling, blisters, or charring, and any of the associated secondary injuries that are going to come with this. Again, not being distracted by that particular injury. Sample history is also part of your good history taking. You guys always want to know what are the signs and symptoms, the allergies, the medications. In regards to your secondary assessment, we're always going to do that physical examination. You're going to perform a full body assessment. Never get distracted by that injury. And then if it's a burn, we're going to make sure that we get a rough estimate of the burned area. That's that rule of nines, remembering that as the person is younger and smaller in age, that their head is going to be significantly more of the actual nines. Again, that was 9, 12, and 18 when we get down to a toddler. And then try to classify your burn and the body surface area that's there. And you just have to approximate it. It's not very specific. We're not getting down to a BSA of 37.5. It's quick and dirty. Like, does this look like it's 20% of the body, 40% of the body, 60% of the body, 90% of the body, and how are you going to treat that appropriately? Package your patient for transport. Try to keep them warm, but you want to cover the burns with sterile dressings and make sure that they're not going to become dehydrated or hypothermic. In regards to thermal burns, we have a couple of different types. We have a flame burn, and that's an open flame, and that's the most commonly caused thermal burn. And then we have a scald burn, which is hot liquid. And we can also have the steam burns, and this is where we get that steam conversion from water to steam, and this can actually cause significant burning and airway burns because it's in a gaseous state and it can be inhaled. Flash burns can be explosions or lightning. Again, inhalation burns can cause serious problems. Do not take them lightly. If you have anybody that has potential for an airway burn, you need ALS intercept or the appropriate facility as soon as possible. These patients are not to be left on scene for any longer than absolutely necessary, and we want to get there. If we're talking about inhalation of chemicals or other particulates, this is also a big problem. These patients may not have any of the black soot around the nose or the mouth, but if they've inhaled something that's going to cause some kind of flash pulmonary edema, they are going to have decreased O2 sats. Make sure that you're staying on top of that. Use that MOI as a good indicator for where you need to be or who you need to be meeting with as quickly as possible. You can always have some severe swelling in any kind of respiratory or inhalation burn. One treatment that you can do is nebulized saline to help cool and reduce some of the swelling. It unfortunately doesn't have a whole lot of effect as the swelling starts to kind of come on. So that ALS intercept and making sure that you can get to the appropriate facility quickly is paramount to their survival. Anybody that's been in some kind of a smoke situation where there's like say a house fire where they had some kind of ability to inhale the byproducts of that fire, they are going to be likely candidates for carbon monoxide poisoning or cyanide poisoning. These patients need to be treated as such, and they're going to need the proper drugs to treat these injuries. And so again, ALS intercept or the appropriate facility, And if it's in your scope of practice to treat this, which in the case of hydrogen cyanide, that's your hydroxycobalamin, and this should be on your radar. And everybody should be able to figure out how to utilize these drugs because these are life-saving compounds in these particular cases. Okay, so now we're going to talk about chemical burns. And chemical burns can happen anytime that we have a toxic substance that contacts the body. Some of the bigger key players to this are going to be strong acids or alkalis. And in this picture, we have somebody who's got a significant eye injury. There's a lot of discoloration there, which I'm not sure why the discoloration's there, but we'll just assume that he's got some kind of contact with the eye. When we're talking about strong acids or alkalis, we would be talking about things such as muriatic acid, which is pool cleaner, or something along the lines of battery acid, which is sulfuric acid. If either one of those acids comes into contact with an eye, it can almost immediately lead to blindness. And then when you're talking about alkalis, one of the ones that would be a key player for people who just generally don't have a strong idea of what's going on is products like the drain cleaners and stuff like that. Like you're talking about drain cleaners or oven cleaners. These contain a product called sodium hydroxide, which is also known as caustic soda. It's very, very alkaline and will cause significant tissue damage if it gets into mucous membranes or the eyes quickly. The eyes are really vulnerable to any of these kind of compounds or chemicals, and unfortunately a lot of people don't wear a lot of PPE when they're dealing with it because it's just over-the-counter stuff that they think that they can get, so it must be relatively safe. You should be considering whether or not there's such an exposure that you need a hazmat team to come retrieve your patient for you because you never want to be the next patient. Now, the severity of the burn can be directly related to the pH of the agent. And remember, 7 is a neutral. And as we get less, that's going to be acidic. And if it goes higher, it's going to be alkalytic. And 0 and 14 are the two maximum values. And both of these are significantly problematic. Stomach acid, generally which is hydrochloric acid, will sit somewhere around the pH of 2, if that puts anything into perspective for you. So the length of time that patient was exposed is going to be another big contributing factor, and then how much of it was actually come into contact with them, and what was the physical form. If you had something that was a dry powdery agent and the only way that it's creating any actual harm is as it becomes wet, this is a little bit easier for us to deal with because we can brush off the majority of the actual component and then profusely irrigate to get the rest of it away from them. The industrial accidents are the more frequent types of this chemical exposure. But again, think about just the couple of examples I gave you where you have something like a drain cleaner or an oven cleaner that can cause these kind of issues. So here's a pretty simple picture where they're just kind of taking away the offending agent from the person's skin. Again, they're dry brushing off any of the material that they can off of the skin. They've got the patient's clothing removed so that nothing's trapped underneath it. They know where it's all at. And as they get closer and closer to it being have been removed from the skin, then you can get into an irrigation factor. Anytime you're dealing with burns to the eyes or any kind of contact with chemicals to the eyes, we're going to copiously flush the eye. And again, that's not 10 cc's. We're talking about 100, 200, 500, maybe a liter in each eye. You have to make sure that you're flushing this. If you look at most of the warning labels on particular chemicals or agents, it will tell you to flush the eyes from anywhere from 10 to 20 minutes. So pay attention to this and make sure that you're trying to do the best that you can to get that agent away from that mucous membrane, which is inside the actual orbit. We do not want to let that patient experience any more pain, discomfort, or loss of vision than necessary. Electrical burns. In this picture, you can see there's a small child that's getting ready to, looks like maybe stick some keys into an electrical outlet. Electricity is going to flow like water. It's going to take the path of least resistance. So in this, if you're following the arrows, it's going to leave the wall. It's going to run down the arm, through the torso, and then through the same side on the leg where the knee is making contact with ground. This is really, really problematic in regards to children because of the potential for injury. And as things get a little bit more safety engineered, it gets a little bit better. But there's always the potential for this. And one of the things that I want to make sure that I stress for you is that the amount of voltage is not necessarily the prime indicator of what the injury potential is. More people have probably died from 110 volt simple receptacle in a house than 240 or 480. And we may become lackadaisical with regards to taking our safety precautions when we're dealing with electricity. But again, it's these low-lying events that are going to do the most damage if you get caught in the wrong situation. Here's a good picture of an exit on the burn injury from where electricity obviously went into an upper extremity and then left at the foot. Electricity is always looking for ground, so it's going to find its way there, again, in the least resistance. And so it's going to find the shortest route to ground that it possibly can. And unless you're completely isolated from ground, you are a prime target for allowing electricity to flow through the body. Obviously, high voltage, high amperage power lines are lethal almost instantaneously. So if you have a patient who is being actively electrocuted, you do not want to touch that patient, right? That's not something that you're going to try to remove. You will become a secondary patient because you now also will become the new easy way to ground. So in this particular slide, again, this is one of those things I'm going to tell you flat out, I do not agree with the slide. You are not looking to determine the voltage and the type of current. AC or DC and the voltage means nothing to you. It's, does this patient actually have an electrical burn? How much damage was there? And is there any organs that were in the pathway of this? So all you need to know is this patient injured? How badly, and where do I need to be at? All right, now we're going to get into that radiation burn. And so radiation burns, like the slide says, this is as simple as the sun, right? The giant ball of fire in the sky is actually using radiation to warm the earth, and it's also what's going to cause the burn on the skin if left exposed without any protection. X-rays can cause burns and other diagnostic machines if too much of a dose is given over too short of amount of time or too prolonged of amount of time. Tanning beds are mimicking the sun, and they're giving off ultraviolet light as well, and so that also is a radiation burn. And then the unlikelihood of a radioactive element in, like, say, a nuclear power plant could also cause these burns. Detonation of nuclear weapons, the flash burn from the explosion is a possibility, although it typically seems to be that there's many other pathways for any of those kind of weapons to actually cause death or injury. In regards to radiation, we have a couple of different types of particles. We have alpha particles, beta particles, and then gamma rays. All of these require some kind of direct exposure, and there are a couple of different pathways for you to actually have this happen. Any of the three can actually attack the surface of the skin, but the bigger thing is whether or not you've actually inhaled or ingested these as they're radiating to the mucous membranes and the tissue inside the body. Now, what you may not know is that alpha particles can literally be deflected with something as simple as a piece of paper. Beta particles, for the most part, heavy clothing and material like that can actually stop the majority of those. Gamma rays having the highest significance to somebody actually having radiation problems, and this is typically only stopped with many, many feet of concrete and lead, and these rays were actually, any of these radiation particles knock chunks out of the DNA in the cells, and it causes the cells to die because they are actually incomplete in their ability to reproduce or divide. So soft tissue injuries can be pretty significant. Again, it's not something that we see a lot where they're very significant, but you will see a lot of mild trauma that mostly involves soft tissue. Always try to make sure that you're not being distracted by something that you don't see regularly. Do your secondary assessment, find a problem, fix it, and move on. And by fix it, I mean just treat it to the best of your ability. If it's bleeding, stop the bleeding. If it needs to be covered and dressed, cover and dress it. Get these patients to the appropriate facility as quickly as possible, and make sure that you're doing the best job you can for your patient. As always, if you have questions, bring it up in class. We'll try to build some kind of scenario, or we'll discuss it in further detail. There's a lot of different things that we could go over in regards to all of these injuries and get way deeper into the pathophysiology. but it's not appropriate for the lecture.